Here is a detailed comparison of osteomyelitis and ankylosing spondylitis across 15 key aspects. 1. Definition. Osteomyelitis, a serious infection of the bone and bone marrow, usually caused by bacteria. It leads to inflammation and destruction of bone tissue. Ankylosing spondylitis, a chronic autoimmune inflammatory disease that primarily affects the axial skeleton, especially the spine and sacroiliac joints, leading to pain and progressive stiffness. 2. Cause. Osteomyelitis, caused by bacteria, most commonly Staphylococcus aureus, fungi, or mycobacteria, can enter the bone through bloodstream hematogenous, open fractures or wounds, direct inoculation, nearby infected tissue, contiguous spread. Ankylosing spondylitis, idiopathic, but strongly associated with genetic factors, especially HLA-B27 antigen. It is an autoimmune response that leads to chronic inflammation of the joints. 3. Symptoms. Osteomyelitis, localized bone pain, swelling, redness, and warmth at the infection site, fever and chills, limited movement of the affected limb. Ankylosing spondylitis, chronic lower back pain, morning stiffness that improves with activity, pain in sacroiliac joints, buttocks, or hips, fatigue, gradual loss of spinal mobility. 4. Onset and progression. Osteomyelitis, sudden or acute onset, especially in children, can progress quickly without treatment, may become chronic if inadequately treated. Ankylosing spondylitis, insidious onset over months or years, typically begins in adolescence or early adulthood ages 15 to 30, progressive with potential for spinal fusion over time. 5. Affected areas. Osteomyelitis. Any bone can be affected, long bones in children, vertebrae in adults. Common sites, femur, tibia, spine, pelvis. Ankylosing spondylitis primarily affects spine and sacroiliac joints. May also affect hips, shoulders, ribs, and peripheral joints. Diagnostic tests. Osteomyelitis. Blood tests. Elevated WBC, CRP, ESR. Blood cultures to identify the organism. Imaging, X-ray, late changes, MRI, early detection, CT scan, bone biopsy, definitive diagnosis. Ankylosing spondylitis, blood tests, HLA-B27 positivity, elevated ESR CRP, imaging, X-ray, bamboo spine in advanced stages, MRI, early sacroiliitis. Clinical criteria, ASAS or modified New York criteria. 7. Treatment. Osteomyelitis, prolonged antibiotics, IV or oral, 4-6 weeks or longer, surgical drainage or debridement in chronic or unresponsive cases, removal of infected prosthetic devices if necessary. Ankylosing spondylitis, NSAIDs for pain and inflammation, TNF inhibitors, e.g. etanercept, infliximab, or IL-17 inhibitors, physical therapy and exercise, DMARDs for peripheral joint involvement, e.g. sulfasalazine. 8. Prognosis. Osteomyelitis, good with early diagnosis and appropriate treatment. Risk of chronic infection or bone necrosis if untreated. Ankylosing spondylitis, variable. Some maintain function with minimal symptoms. Others may develop spinal fusion, decreased mobility, and disability. Complications. Osteomyelitis, chronic infection, bone abscesses, pathological fractures, sepsis. Ankylosing spondylitis, spinal fusion, ankylosis, kyphosis, forward curvature of the spine, eye inflammation, uveitis, cardiovascular complications, aortitis, restrictive lung disease due to chest wall involvement. 10. Epidemiology. Osteomyelitis can affect all age groups, more common in children, older adults, and immunocompromised individuals. Ankylosing spondylitis primarily affects young adults ages 15 to 35, male to female ratio about 3:1. More common in HLA-B27 positive individuals. Past 11. Pathophysiology. Osteomyelitis, infection, inflammation, increased intramedullary pressure, vascular compromise, bone necrosis. Ankylosing spondylitis, autoimmune response, chronic inflammation, erosion of cartilage, new bone formation, spinal fusion. 12. Chronicity. Osteomyelitis may be acute or chronic. Chronic cases involve persistent infection and require long-term care. Ankylosing spondylitis, always chronic, lifelong disease with remissions and relapses. 13. Systemic involvement. Osteomyelitis, primarily localized, systemic symptoms, fever, malaise if infection spreads. Ankylosing spondylitis, systemic inflammatory disease, can involve eyes, uveitis, heart. aortic regurgitation, and lungs fibrosis. The 14 findings: osteomyelitis, bone lysis, sequestrum involucrum in chronic cases, MRI, bone marrow edema, abscess formation, ankylosing spondylitis, early sacroiliac on MRI, late bamboo spine, fused vertebrae, syndesmophytes, squaring of vertebral bodies. 15 response to treatment: osteomyelitis, good response to targeted antibiotics, surgery effective when needed. Ankylosing spondylitis, NSAIDs effective in early stages. Biologics improve symptoms but not curative. Physical therapy critical for preserving function. Summary table: aspect osteomyelitis, ankylosing spondylitis, nature infectious autoimmune, cause bacteria e.g. staph, genetic autoimmune HLA-B27, onset sudden, gradual, age group all ages, young adults 5 to 35, site any bone, spine and sacroiliac joints, key symptom local pain and fever, back pain and stiffness, fever common, rare. Diagnosis: MRI biopsy, cultures, X-ray, MRI, HLA-B27. Treatment: antibiotics, surgery, NSAIDs, biologics, exercise. Prognosis: good if early, variable, can be disabling. Imaging: bone destruction, bamboo spine, sacroiliitis. Systemic signs: sepsis, abscess, uveitis, itis. Complications: chronic infection, spinal fusion, chronic, sometimes always. Contagious? No. No? Thank you. Have a nice day.